Thanks very much, Bruce, and thank you very much for the introduction. I always love talking on gout, so I'm very happy to be here to give you this update. I'll just show you this amazing image, which is just describe this. So this is a dual energy CT scan, and these are scans that we use a lot in our research now to try and understand mechanisms of joint disease in patients with gout. And I think this is a really beautiful example of the 2 feet of a patient with gout, and just demonstrating the crystals here color-coded in green in this patient with tophaceous gout. So this is very severe disease. This is the kind of disease that we're really trying to avoid, but unfortunately we do frequently see this in our patients in Auckland. These are my disclosures. I will just point out that most of these relate to new urate lowering therapies that are currently under development, but I will be discussing febuxostat, which is marketed by Takeda in the US and Menarini in New Zealand and in Europe. So that is a potential conflict related to my talk today. So I'm going to give you a brief introduction to the epidemiology of gout in Aotearoa, New Zealand, with some updated data from the New Zealand Health Tracker. Talk a little bit about pathogenesis, really, I think, to give you kind of a more deep understanding about the treatment that we're using for gout, and some of the recent updates in our understanding about gout management, and finally mainly focus on treatment, and really focus primarily on pharmacological therapy, but also talk a little bit about non-drug therapy. So gout is the most common form of inflammatory arthritis in adults. And as all of you, I think, will know, it's essentially caused by the inflammatory response to monosodium urate crystals. So these needle-shaped, negatively birefringent crystals that can be visualized when we aspirate the joints from patients with gout. So these crystals form in the presence of hyperuricemia, so high serum urate concentrations. And so hyperuricemia is really a key element of gout pathogenesis. So these are data from the New Zealand Health Tracker, and these are data from men in 2009. And here we can see on the x-axis data the ages. So this here is 20 to 25, and out here we've got 85 plus. On the y-axis we have prevalence data, and this is up to 50%. So this isn't to 100, 100's up here somewhere. This is 50%. And what we can see in men is that, and this is for the entire New Zealand population, looking at NHI-linked data, we can see that the prevalence of disease increases with increasing age in men, and really plateaus at around 75 years. And here in older men, overall in New Zealand, we're seeing about over 10% of older New Zealand men with gout. And I think not surprising to us who work in the health field, we see differences between ethnicities. So in light blue here we see New Zealand European, in red Asian, and Asian and New Zealand European pretty much sort of track maybe just under the overall prevalence for the entire population, but much higher rates in Pacific men in green, and in Māori men in dark blue. And you can see that really at every age, much higher rates in Māori and Pacific men. And of course, this is kind of not something I think that is that surprising for us. But I think when you look at the actual overall prevalence, particularly in older Māori and Pacific men, it's really pretty striking. So here we're seeing over a third of Māori men, older Māori men with gout, and over a quarter of Pacific men, older Pacific men with gout. So really a major and important form of arthritis in these populations. And when we look at the data in women, a similar pattern with respect to ethnicity. Of course, gout is a lot less common in women and really most often presents after the menopause. But again, these very big differences in ethnicity with much higher rates in Māori and Pacific women, really at every age group. And here, over 20% of older Māori women are affected by gout. So again, an important health problem, particularly for Māori and Pacific people in New Zealand. So that's looking at overall prevalence, but what about the impact of disease on the patient? This is, I think, a very interesting quote from a study that we did a number of years ago now, which was a qualitative study looking at the experience of gout for people in New Zealand. And you can read this quote, but I think it really gives an impression of actually how severe the pain of gout actually is. So this cooking, severe hot pain, feels like your flesh is going to rip open or burst. I mean, this is not a minor experience for people. This is a very severe and painful condition, and really does have a big impact on people, both with respect to their sort of musculoskeletal function, their ability to work, their ability to participate in family activities and so on. So again, the experience of gout is not trivial. And it's an incredibly painful experience for patients. And of course, gout doesn't just travel by itself, it travels with many other comorbidities. So when we see a patient in the clinic with a big toe, invariably there are a whole lot of things that run with it as well. So most of these patients have metabolic syndrome, and in fact many of us really think of gout as part of metabolic syndrome. Hypertension, very common, and really probably the majority of people with gout. Chronic kidney disease, very common, affecting almost half of people with gout, and diabetes and coronary artery disease in about a third as well. And of course, all of these make it much more complex when we're thinking about actually how we manage people with gout with respect to the medication choices that we make. So if we think about the key checkpoints in gout pathogenesis, hyperuricemia is really central to this, and without hyperuricemia it's extremely unusual to have gout. In some people with hyperuricemia, crystals form, and in some people with crystals, acute gouty arthritis forms, and this is typically a self-limiting acute inflammatory arthritis. And in some people who form crystals, they also develop chronic gouty arthritis and tophi. So if we first think about what's going on with hyperuricemia, now I know that Bruce told me I wasn't allowed to present a biochemical pathway, so I'm not going to go through this in detail because it kind of gives me nightmares from med school as well. But I will just point out that urate is the end product in humans of the purine degradation pathway. And there are these very complicated pathways of purine salvage, and a number of risk factors for gout feed into these. So this includes things such as high purine diet, alcohol and fructose, and these are all of the kind of things that we traditionally think of as being associated with gout and important for developing gout. And certainly for some individuals that's the case. But actually what's become clear is that kidney transport is actually really the key determinant of serum urate concentrations, and that there are a number of different transporters within the kidney, within the proximal renal tubule, that lead to uric acid being secreted and also reabsorbed. And it's really this balance of these transporters that actually regulates the serum urate concentration. And it's also these transporters that interact with diuretics to increase the serum urate concentration. So in the last 10 years, there's been really a major advance in our understanding of gout related primarily to genetic studies, which have really clearly demonstrated that actually it's the urate transport within the kidney and also to some extent within the gut that's actually really most important for regulating serum urate concentrations, far more than purine synthesis pathways. So I think that these data have, they're very interesting to people like me who are really interested in the pathogenesis of gout, but I think that they're also really important if we're thinking about our concepts of disease around gout and our attitudes towards gout. So there's this kind of concept within the general population, often perpetuated by us as healthcare professionals, that gout is really all about what the patient eats and drinks. It's all about, oh, you've eaten the wrong thing again, you've been out on a bender, you've had all that beer. Whereas actually, in actual fact, this is a very small contributor to development of gout, and genetic risk, and in particular genetic risk around renal transport and gut transport of uric acid, is a far more important determinant of the risk of having a high serum urate concentration, or indeed developing the disease itself. And I think when we approach patients and when we think about the treatments for them, having that concept of disease is very important. So the next key checkpoint is the formation of uric acid crystals, or MSU crystals. So there are a whole lot of different things that contribute to this, including temperature, concentration of urate, pH, but at the temperature of the big toe of around 35 degrees, the concentration at which crystals start to form is 6 milligrams per deciliter. And that aligns to the treatment target that we often talk about of 0.36 millimoles per litre. So that's really where that target initially came from before it was studied in various studies for clinical outcomes. In some people who have crystals within the joint, acute gouty arthritis forms. And again, I'm not going to go through this biochemistry in great detail, but just really to, again, emphasize that there's been enormous breakthroughs in understanding around the pathogenesis of the acute gout flare. And IL-1, the cytokine IL-1, is really key in all of this. And there are now a number of studies that show that IL-1 inhibitors can, in fact, prevent and treat gout attacks very frequently. Now, these are quite expensive biologic treatments, so they're certainly not something that I'm using in my practice, but again, I think we're seeing enormous new insights into the understanding of gout management. And finally, for people who have persistent hyperuricemia with formation of a lot of crystals, chronic gouty arthritis can occur. And unfortunately, this is something that we see frequently when patients are presenting late, when they haven't been established on urate-lowering therapy with tophus formation. So this is the kind of very severe disease that we unfortunately do see at times in our patients. And essentially, these tophi are collections of MSU crystals surrounded by a chronic granulomatous inflammatory response. And these tophi are very important because essentially they contribute to joint damage in patients with gout. And these are data from one of our recent dual energy CT studies where we can see that these patients who have large gouty erosions have the crystals within the tophi present at the site of erosion. So this is what we're really trying to avoid. In addition to the morbidity of flares with respect to work disability and loss of participation, actually, essentially, pretty permanent joint damage in patients with very severe tophaceous disease. And this is really, for most patients, a preventable consequence of disease. So that's really the background as far as the science. I'm now going to focus now on a more sort of practical element around treatment of gout, but hopefully that background will provide you with some, I guess, some sort of context of how we approach gout management. So my kind of concept of gout management is that there's three main strands. So obviously when the patient presents to us with an acute flare, it's very important that we effectively treat that. And we can do that with a number of options. And these are all pretty, widely used, widely available treatments. So non-steroidal anti-inflammatory drugs, colchicine or prednisone, intra-articular corticosteroids also work very well. For some patients in certain contexts, particularly for those who are starting urate-lowering therapy, anti-inflammatory prophylaxis is also important. And we can do this in a number of ways: low-dose NSAIDs, low-dose colchicine, and occasionally we need to use low-dose prednisone. And then we have urate-lowering therapy, and this is really for gout prevention, and this is for crystal dissolution. So here we can see xanthine oxidase inhibitors, and this is either allopurinol or febuxostat, or uricose uric drugs, probenecid or benzbromarone. So I'm going to spend most of my time talking about this because this is really the key element of effectively managing gout long term. So one of the questions that often comes up is, well, who should be on urate lowering therapy? And I have to say that this is a somewhat moving target, but I've shown you here the guidelines from the 2012 American College of Rheumatology guidelines, and this is certainly, I think, the practice that most, or the guidelines that most rheumatologists would recommend at present. So essentially these are people who have an established diagnosis of gout. So these are not people with hyperuricemia alone without any clinical evidence of gout. So essentially an established diagnosis of gout, and then one of the following. So frequent attacks, and by frequent attacks we're saying 2 attacks or more within a 12-month period. Tophi present on imaging or examination. Chronic kidney disease, or previous kidney stones. The other issue that has come up quite recently with a number of clinical trials is when to start urate-lowering therapy. And I think, again, certainly my practice has changed quite a lot around this. So in the, up till a couple of years ago, the thought was that actually we shouldn't be starting allopurinol or other urate-lowering therapy during an acute flare, that we should wait for at least 2 weeks until the flare had settled and then initiate urate-lowering therapy. There have now been a number of clinical trials, most of which are quite small, but I think overall have a very consistent finding that there's no evidence that starting allopurinol or other urate-lowering therapy at the time of a flare actually alters the outcome with respect to the flare itself. And I think that there are definite advantages in actually starting allopurinol at the time that you see the person with a flare, particularly the advantage that actually it's an opportunity. And it's an opportunity where gout is, where the impact of gout is probably really at its highest. And I think many of us see, or used to see patients at least, where patients were flaring very frequently, and actually they really never got onto allopurinol because every time they thought about starting it, they'd have another flare. And it also, I think, sort of led to a lot of confusion for patients, and I think also for practitioners around, well, what should I do when the patient has a flare? Should I stop it? Should I start it? What should I do? And I still see patients who, who say, oh yes, I've stopped it because I had an attack. And so again, I think initiation during a flare is fine, and then it should be, unless the patient has an adverse event, allopurinol should be continued, or the urate-lowering drug should be continued long-term with no interruptions to treatment. And as I've mentioned, no clear evidence for urate-lowering therapy in people with asymptomatic hyperuricemia. So again, if you remember nothing else from this talk, I hope you go away with this number, 0.36 millimoles per litre, because this is really the key treatment target for patients who are on urate-lowering therapy. So if you're treating someone with allopurinol, my view is that we have a responsibility to use it properly, and we have a responsibility to use it at a dose that's going to lead to an effective treatment target. So for the vast majority of patients, this is the appropriate treatment target. And this is the target that leads to crystal dissolution in vitro when we look in the lab, but also it's the target which has been associated with dissolution of crystals in synovial fluid in patients with gout, suppression of flares, and this is the level at which we start to see regression of tophi. If we have patients with a lot of tophi or with extensive tophaceous disease, we should be aiming for a lower target, and that target is said to be 0.3, and probably actually the lower the better, but I think certainly below 0.3. So when we're seeing patients with gout, and certainly again my practice I think has really evolved around that, really the first thing I do when I'm thinking about management is thinking, okay, so what's the treatment target for this person? And really having a conversation with the patient about that, and really explaining to the patient that this is what the target is, and the reason that we're trying to achieve this is because this is where we see the crystals dissolving, this is when the gout flares are going to start decreasing, and this is the level at which we really know that the medication is going to work. That is the first step when we're initiating urate-lowering therapy. And I think that then makes it then guides practice in a very sort of intuitive way thereafter. So allopurinol is certainly first-line treatment for management of gout. It's certainly the drug that I use absolutely is first line, and it's certainly very widely used in New Zealand. I think it's really still the major urate-lowering drug that's used throughout the country. And it has a lot of advantages over some other drugs, particularly uricose uric drugs. It can be used just once a day. There's not a requirement for fluid, a lot of fluid intake advice, which is what we do have to do for drugs like probenecid. And although it mainly has an effect on urate production, it actually works very well and is really effective irrespective of the cause of hyperuricemia. It's also very cheap, so it costs less than $10 per annum for 300 milligrams daily. So, I think clearly from a pharmac perspective, this is very appealing for pharmac, certainly. Back to my banned enzyme pathway slide. I'll just remind you that allopurinol works down here. So it inhibits xanthine oxidase, so it essentially inhibits production of urate. And just to remind you again that we do need to be very cautious for patients who are on allopurinol because of the interaction with allopurinol and azathioprine. So many of you will be familiar with these old guidelines around allopurinol dosing. And these were very widely disseminated and very widely recommended actually by rheumatologists, including a number of rheumatologists in New Zealand. And we had some very fancy dose calculators which told us exactly what our dose should be according to these guidelines. So these were published in the 1980s and essentially said that the lower the creatinine clearance, the lower the maintenance allopurinol dose should be. The problem with this kind of approach is that basically very few people actually achieve target serum urate with this kind of approach. So these are data that, from Counties Manukau DHB that we published over 10 years ago now, when we reviewed our practice and looked at those who were on recommended doses of allopurinol according to the handy criteria and found that less than 20% were actually achieving target. At that time there were a few patients who were on higher than recommended doses, certainly quite different to what we do these days, and in fact there were substantially more who were achieving target on the higher than recommended doses, but still actually pretty low numbers. This is only 38%, so really pretty poor targets with dose adjustment according to creatinine clearance. So essentially, this kind of approach of maintenance dosing of allopurinol, according to creatinine clearance, really does not lead to treatment targets for most patients. So why are we so worried about allopurinol doses in the context of kidney function and creatinine clearance? Well, this is the reason why. Allopurinol hypersensitivity. So this is a very rare condition. It affects less than 0.1% of people taking allopurinol, but it's a very serious condition. And it's essentially a syndrome that occurs in patients soon after taking allopurinol, where they develop an acute hypersensitivity reaction, severe skin rash, blistering skin rash, kidney failure, fever, eosinophilia, and people die from this. And I think, if you see it, you really, you remember it really. So there are specific risk factors that are associated with this syndrome, and this is really a syndrome that typically occurs early on when you first start allopurinol. So once people have been on it for a prolonged period, there's really no increased risk of hypersensitivity. Oops, I'm sorry. So there are a number of risk factors for this condition. So the time of onset is most important. Diuretic therapy, kidney function. There are some specific genetic markers that are quite common in Chinese populations, HLA-B5801. And the question has really been, is the allopurinol dose important or not? So I'm now going to show you some data from a study that's a national study that was led by Lisa Stamp, who's a rheumatologist in Christchurch. And this is a study looking at, that was a nationwide study looking at allopurinol hypersensitivity and looking at dose as a risk factor, specifically designed to look at dose as a risk factor. And in this study, what we found was that starting dose was indeed a risk factor. So the higher the starting dose, the higher risk of developing hypersensitivity. But when we looked at the maintenance dose, there was really no association. So what this and it's very difficult to really do these studies, and certainly to provide a very good evidence base for dose adjustment, particularly when this is such a rare adverse event. But really based on these studies, what we now recommend is a starting dose of that is renally adjusted. So essentially, from the allopurinol hypersensitivity study, it seemed that 1.5 milligrams per unit EGFR is a safe starting dose. So if you just kind of think about this in the context of your patients, so if they've got an EGFR of 90, then probably the dose that, and you can do a bit of rounding up and down. This is a kind of rough estimate. But if they've got an EGFR of 90, you're looking at a starting dose of about 150, which is a half 300 milligram tablet. If they've got an EGFR of 60, you're looking around 100 milligram tablet. And if they've got an EGFR of 30, then you're looking at about 50 milligrams, which is a half 100 milligram tablet. So certainly dose adjustment for the starting dose, but once the patient is established on allopurinol and they're tolerating it, it appears that it is quite safe to dose escalate to achieve the target. So when we're talking about this dose, we're not talking about staying on it forever. We're talking about this as the starting dose, checking the serum urate. If the patient is not at target, dose escalation until the target is achieved. And certainly for people who have normal renal function, I'd be dose escalating by about 100 milligrams every month. If they've got chronic kidney disease, probably 50 milligrams a month. And I would also say that patients who have chronic kidney disease often actually need less allopurinol because they're not clearing it as much. And so often patients with chronic kidney disease will get to target at lower doses, perhaps 200 milligrams, maybe even 100 milligrams. So every person is different, but that dose titration is very important in order to actually achieve it. And certainly in studies, this is another study that Lisa Stamp did, but there's also a number of other studies from the UK as well, that actually dose escalation does lead to most people achieving target serum urate, certainly more than 85% of patients. So it's really personalising this for each individual, starting off on a safe starting dose, checking the serum urate, and monitoring the serum urate with gradual dose escalation. What about if allopurinol just isn't tolerated or isn't effective? Well, there are a number of other options now, and certainly I think in the last 5 years we've really had major advances in New Zealand with new agents available, which has been very, really an excellent advance for our patients with gout. So probenecid, many of you will know because of your concomitant use with antibiotics, but of course it is a very good urate lowering drug as well. And certainly it's a drug that we use quite often in combination with allopurinol or a second line for patients who are not achieving target or can't tolerate allopurinol. Patients on probenecid do need to drink a lot of fluid, so at least 2 litres a day, and if they've had kidney stones, probenecid shouldn't be prescribed. And it is certainly less effective, particularly in patients with severe chronic kidney disease. Febuxostat and benzbromarone are available on special authority, and I'll talk a bit more about those now as well. So just to remind you that essentially the uricose-uric drugs act through that they're targeting specific transporters in the kidney, so they're again targeting these transporters that are regulating the reabsorption of uric acid. And febuxostat acts on the same pathways as allopurinol, so xanthine oxidase, but it's a more specific and potent inhibitor of xanthine oxidase compared with allopurinol. And remember also that the same issues around drug interactions with azathioprine relate to febuxostat as they do with allopurinol as well. So if you've got a patient with allopurinol who's on azathioprine, febuxostat isn't a good choice rather than allopurinol. You need to think about a uricose-uric drug. So febuxostat, as I said, it's a selective inhibitor of xanthine oxidase. It's metabolized by the liver, so it doesn't require dose adjustment in kidney failure unless it's very severe. It can cause deranged liver function tests and hepatitis, so patients do need to have periodic liver function test monitoring. And the current data sheet, MedSafe data sheet, also states that febuxostat is not recommended in those who have ischemic heart disease or congestive heart failure, which is kind of problematic because often patients with gout do have these, but that is what's currently stated on the data sheet. With respect to dosing, 80 milligrams is often sufficient, but there is also a 120 milligram tablet as well. And certainly it's significantly more effective than fixed dose allopurinol, but in the clinical trials, really allopurinol doses were quite limited and only up to 300 milligrams a day. So we don't know at present how well febuxostat compares to, say, 600 milligrams of allopurinol with respect to urate lowering. So it is available on special authority. Any practitioner can request the special authority. The special authority has to be updated every 2 years. And essentially, Pharmac have funded this for patients who have failed allopurinol at doses up to 600 milligrams daily and probenecid up to 1 gram BD. If patients have severe chronic kidney disease, they don't necessarily have to tick the probenecid box. But really, I think Pharmac, at least at present, is positioning this as third-line therapy for patients who have failed both allopurinol and probenecid. Benzbromarone is another urate-lowering drug that is available on special authority. It's a potent uricose-uric drug, much more potent than probenecid. It does require quite close monitoring of liver function tests, and Pharmac states this is mandatory because of the risk of hepatotoxicity. It is funded on special authority by Pharmac, but it's not approved by MedSafe, so it does come under a Section 29. So it becomes certainly in my practice, I think it becomes a little bit more complicated. So I think most of us are now using this as fourth line rather than third line therapy for urate lowering therapy. But certainly, we have used this quite a lot in the past, particularly at counties, and it's certainly a very impressive urate lowering drug as well. And this is basically this is just to show that it is available on special authority. And again, any practitioner, so this is not something that a rheumatologist has to do. If you want to talk to a rheumatologist about it before you do it, if you're not used to it, we're very happy to do so, but any practitioner can apply for this. When we're starting urate lowering therapy, there is a risk of flares, and certainly prophylaxis is recommended. And this can be with colchicine, 0.5 milligrams, either once a day or twice a day. Good clinical trial data to show that it reduces flares. And certainly this would be recommended for at least 3 months, and for some patients 6 months if they're having frequent flares. Just be aware that there are drug interactions, particularly with certain drugs such as cyclosporin and diltiazem, verapamil, clarithromycin, so the dose should be reduced if patients are on these medicines. And low-dose NSAIDs are another option. I have to say I try not to use low-dose NSAIDs regularly because often these patients do have chronic kidney disease and other conditions that make me a bit worried about NSAID use continuously for 3 to 6 months. But there are some patients who are flaring frequently where actually this is a good option to help them actually get onto urate lowering therapy. And I've really talked already a bit about managing flares. A number of, now 3 big good quality clinical trials that show that oral prednisolone or prednisone up to essentially the equivalent of prednisone, 40 milligrams a day, is as effective as NSAIDs. So this is certainly a good option for patients who perhaps can't tolerate NSAIDs. One of the questions that I often get asked about is, well, I always get asked about by my patients is, what should I be doing about my diet? And really there's very little data, actually, that any dietary intervention is effective for people with gout. And most dietary interventions have very small effects on serum urate. So certainly for people who are having recurrent flares, who have tophi, there is really no way that they are going to be able to achieve a target serum urate, go from maybe 0.55 down to 0.35 with diet modification alone by the time they have established gout. So certainly it is important to be asking patients about their alcohol intake, and if they are hazardous drinkers, giving them advice about that as you would with any other hazardous drinker. If they're drinking a lot of sugary drinks, which can increase the urate, giving them advice about that as you would for any of your patients. But a 5-minute conversation about diet is probably 5 minutes that you could spend better actually is getting them onto allopurinol, I think. That's certainly my approach now to the patients that I see. So if we're just sort of pulling this together and thinking about the management plan, I think one of the really key elements for really getting good long-term control of gout is to help the patients to understand the underlying basis of disease. That gout is caused by these crystals that are present in the joint. These crystals form when the urate level is high. When we bring the urate level down, the crystals will dissolve. We need to keep the urate down in order to prevent the crystals from forming again. So this basically, get the urate crystals down has got to get the urate down has really got to be the key message for patients. Really focusing on the urate, actually showing the patients their numbers. You know, I know I've won when the patient comes in and says to me, what was my urate level? Because, you know, ultimately that's the way that we're really going to see, you know, we're really going to target the underlying basis of the disease. And so this is really sort of my, really my summary of my approach to managing gout. So really focusing on the serum urate target, helping patients understand the basis for that, initiating urate lowering therapy slowly and gradually increasing until the target serum urate's achieved, ensuring a consistent supply. And I think that this is a really important issue. I mean, a lot of these are young men who are working, who actually, you know, don't have time to come and see me in a clinic, often, you know, can't come and see, you know, you guys during working hours. And I think, you know, really nationally we need some strategies to actually help patients have continuous supply of these drugs so that they're not having breaks in their therapy. Continuing the urate lowering therapy long term, basically the message that unless you have a side effect from the medicine, you should be taking this medicine every day. If you stop your allopurinol within 2 or 3 days, your urate will be up here again, and you will be at risk of developing flares. Monitoring the serum urate. So once the patient's at target, you know, measuring the serum urate every 6 to 12 months, just to make sure that actually the allopurinol is still really probably going in on a regular basis, as much to monitor adherence as the effectiveness of the drug itself. I think it's also really important to understand the importance of flares for patients and to make sure that patients have a really good action plan for managing their flares. So ensuring that patients know what to do when they have a flare, that they have therapy available so they can treat a flare early rather than, you know, wait for, you know, the next day when things have really blown out of control. Clearly these patients are at high risk for cardiovascular disease, so this should be seen as a red flag for cardiovascular risk assessment and management, and reviewing progress, you know, not being satisfied with a urate of 0.42 or 0.45, and really focusing on that target, because ultimately that's how we're going to actually, you know, deplete the body of crystals and really deal with the underlying problem. I will just also point out to you our gout clinical pathways. These are freely available. If you Google gout and pathway, you'll see the gout pathways, which will talk you through many of the issues that I've discussed, you know, based on the specific patient scenario. Who should the rheumatologist be seeing? This is essentially what we have agreed with in Auckland. So basically those patients where you can't get the urate down despite maximum dose, certainly for those who have a persistent arthritis when the urate has been at target for some time. So often it will take 3 to 6 months to see benefit, but if the patient has ongoing arthritis and particularly ongoing inflammatory arthritis and something just isn't kind of gelling in the way that it normally should, we're very happy to see those patients or discuss those patients with you. And I think, again, you know, if there's concerns about using some of these newer drugs, we're very happy to have a conversation, give advice through e-referrals or by telephone, or see the patient to initiate, you know, particularly the third, fourth line therapies that perhaps people are not quite so comfortable with. We're very happy to have the conversation and to see the patients as needed. And I'm just going to finish by reminding you again about the target, and hopefully this will be embedded on your brain, as it is on mine. Thanks. Okay, so I'm happy to answer questions.
Okay, you'll need to come to the microphone so that it gets recorded on the film. So questions, not statements. So,
what's the dose of probenecid?
So they come as 500 milligram tablets, and often I would start 500 twice a day, and then it can be increased to 1 gram BD. They're quite big, they're sort of horse tablets, they're pretty big, but they do need to be given twice a day, and basically in the morning and in the evening with the evening meal.
And is this a monthly increment?
So I would go 500 BD for a start, check the urate. Some people will get to target there, and if they don't, 1 gram BD.
Within a month?
Yeah, after a month.
Okay.
Yeah.
And allopurinol, what's the maximum?
The maximum approved dose is 900 milligrams.
900.
I don't often use 900. I would often get to 600, 700. Most people will get to target. Most people don't need 900. I've got the odd person who needs 900, but not that many. Yeah.
So I think a lot of GPs are frightened of going above about 300, but but there's no harm to the kidneys.
There really isn't. I mean, I think the key thing is measure the urate. You know, often, you know, these big guys, you know, with normal kidney function will need 400 to 600. And so, provided you're just gradually increasing it, you know, it's fine.
And at what point would you go to allopurinol 600, and if it's not coming down, then you'd add probenecid?
I would normally go to 600 and then add probenecid at that point. Okay. I mean, I think if you haven't seen any shift at all in the urate, I think there needs to be a conversation about adherence again as well, because really, you know, allopurinol will drop the urate in pretty much everyone. So, you know, certainly if I've seen someone who maybe they start off with a very high urate, maybe, you know, 0.7, and they're on, you know, maybe 600 and they're down to 0.5, I'm pretty comfortable that that person's taking it. But if they're 0.7 and they stay at 0.7 to about 600 milligrams, you know, then there's a different conversation.
Yes.
Yeah.
The other option is for Buxostat if you hit the 600 mark. So, if you want to ask a question, come up to the thing. I've got a couple for Nicola. One, if you could make a comment about fructose. And what do you do with the person who's on 300 milligrams of allopurinol and the uric acid is 0.38? That's a situation I've come across.
Yeah, sure.
Do you go to the 2 tablets or do you just leave it?
I believe in treating to a target.
Okay.
As you can probably tell.
Yeah, no, that's right.
And so, you know, I think it always, you know, I think it really depends a lot on the patient. So, you know, I think you know, if the patient is, you know, I think that we need to be careful not to have absolutely hard and fast rules and say, you know, it's terribly wrong, you know, and maybe for some people, 0.38 is okay, but I think in general, we need to be actually achieving the target because there's good rationale for doing that. Fructose is, you know, fructose is really interesting. So I'd seen a lot of the data around fructose. So certainly, you know, as far as observational studies within the general population, with respect to serum urate and risk of gout, there is an association. We don't have good clinical trial data showing what happens if you cut out fructose, because I'm not sure quite how you do that. But we did a study of healthy volunteers where we fed healthy volunteers fructose, quite a big dose of fructose, 65 grams of fructose, and I was really surprised at how much the urate goes up. So the urate will go up, so, you know, in someone like me who probably has a urate of, I don't know, 0.25, it'll go up to 0.35, higher than that actually, you know, acutely within 30 minutes. I mean, it's it's actually a pretty impressive effect. So if you've got someone who's drinking a lot of sugary drinks, that will make things a lot more difficult. You probably, even with fructose avoidance, I don't think you see
a big
complete
change.
Normalisation. But I think, you know, there are so many other advantages to avoiding sugary drinks that, this is part of the whole sugary drink story, I think.
The issue I'm trying to get here is some of these young men, I have these patients who drink 3 litres of sugary Coke a day and they think nothing of it. In fact, they're a bit surprised that I see that as a lot, amongst some peer groups that's completely normal. Is that Zach?
Yes. Yeah.
Question.
Hi, I've got a question, mainly looking for any tips that you have for patient populations who it is incredibly hard to get in to see perhaps monthly or 3 monthly at the best for a blood test and for titrating allopurinol. I mean, is it appropriate to give still appropriate to give a 3-month script where once we've given a specific dose for the creatinine clearance to try to titrate up 100 without seeing them?
I think you can make some assumptions. So I think you can certainly make some assumptions, say, I think this person's going to need at least 300 milligrams. So what I'll do is I'll give them a script for, say, 150 for the first month and then 300 thereafter, or, for the first couple of months. We do a lot now, just phoning patients, community labs, sending out scripts. And I think we've got to be doing more of that. I think it's really unreasonable to be expecting these guys who are working full-time, supporting their families, who maybe had time off, have had a lot of sick leave because they've had, poorly controlled gout, to then be taking time off to come and see us. I think we've got to really think strategically about that. There's quite a lot of interest now in monitors, and there are some effective, point-of-care monitors as well, and I think that's another, good strategy.
Is that in New Zealand yet, point-of-care monitoring?
Yeah, there are some point-of-care monitors in New Zealand.
For serum urate. Okay.
So that's another, there have been some issues with reliability of some of them, but certainly there are some that are actually really quite reliable.
Is that within counties and Auckland DHB? Is that available?
There should be some available in Auckland, yeah. Yep. And
they're not funded though, I think is the issue, isn't it?
So this is basically for use in primary care, so you can actually get the urate at the same time, and at the same time that you're seeing the patient, so you've actually got an immediate result. So I think that's certainly it's certainly a strategy that, then at least the patient doesn't have to go to a separate lab on a separate day and then waiting for the result and so on as well.
Are you aware, just for the crowd here, where we can access those or how much they cost or which medical company supplies those machines?
Maybe I'll get back to you on that.
Yeah,
maybe you could just,
The company that were providing for Buxastat used to provide them, but then I just had a conversation with them.
Yeah, they're not there were some issues with those ones, but I think there are some others available that that actually do appear to be quite reliable. So, I think there's also a lot of community resource as well. There's arthritis educators. The arthritis educators have a portable uric acid meter process. So, there are community resources out there, but I think more and more, I think we just need to look at actually, ensuring, mailing out scripts, community labs, actually doing, you can do a lot of this remotely, especially once you know what the target is and you're focusing on the target. Actually, the key thing is ensuring maintenance of prescribing, really.
Well, we can't do the traditional thing, come in every 3 months. It just doesn't work. It's a patient population that aren't familiar with the health system. They're not coming in for anything else, and you're telling them to be on a pill for the rest of their life. It takes a lot. We're looking at case managing these people for 2 years now. That's going to be our little project, because I suspect it's going to take that sort of input. So a nurse phoning them up regularly to make sure they're taking. And I think we should be posting things out and doing things on phone. We don't need to see people every 3 months. We get capitated money. A lot of PHOs have flexible funding to cover that now, and I think we should be pushing the PHOs for flexible funding. It really makes quite a difference.
I'd also say that I think nurses and pharmacists are really key in this. So this is something that can be very nicely protocolized, and nurses are really good at this. There's actually a couple of clinical trials that show that really good outcomes with a nurse-led and a pharmacist-led approach to particularly dose escalation, and having that approach of, actually that education approach and the kind of chronic care management approach, I think is definitely the way to go.
And patients love phone calls, they're just amazed when, I don't know how much you've done of that, but, they sort of gasp for the first minute that you've phoned up, and then you have to sort of calm them down and start talking to them. So that'd be my experience. But, I've got another question for Nicola. So if you want to have questions, please come up. I'm mentioning this woman to me. She was an older Māori woman with a family history of gout, and she kept getting problems with allopurinol, and she didn't like taking febuxostat, and we weren't 100% sure she had gout. She had one of those dual energy CTs, and she did have gout. So I just wonder if in those people, when you're not sure what they've got and you're having trouble with the medication, and we're getting a bit desperate with this lady, like, what do we do?
I think I talked quite a lot about gout in the gout diagnosis in the clinics I did, and I wanted to focus here on management. But certainly there are a couple of other new methods for gout diagnosis, so dual energy CT and also high resolution ultrasound. I think ultimately we should be able, in the vast majority of cases, to diagnose gout in our clinic, history and examination, joint aspiration as needed. And certainly joint aspiration is very useful, to get a crystal diagnosis. That's still the gold standard for diagnosis. But there are these new methods for detection of urate. And I think one of the really interesting things I've found is that, particularly with the dual energy CT, is that you can actually visualize the disease in a really amazing way that we've not been able to do
those
before.
pictures are extraordinary, aren't they?
And it really helps us understand that actually, even when patients aren't flaring, the crystals are still there. And so I think from a kind of education, urate lowering therapy adherence perspective, it's really very powerful. But I also think for those unusual cases where, and we do see them, where there's a sort of unusual presentation, that these methods are very useful in that respect as well.
Well, this was incredibly useful because this woman had ankle pain that was coming and going, and the side effects didn't sound like allopurinol. Allopurinol, I have to say, is the one drug nobody complains about. I have to say, of all the things I give people, I've never had, other than this woman, and it was very liberating to have that thing, because now she's on allopurinol. We're happy to sort of walk her through that, and her urate's perfectly well controlled.
And I think, having certainty of diagnosis is really important in that
because there was uncertainty about the treatment, and we were really not Peter, last question, and then
Nicola, the patients who fall off allopurinol make me feel tired, and it's largely due to this issue of, do we need to prophylax them with colchicine, low-dose non-steroidals every time we restart their allopurinol? Have you got a rational approach to this?
Yeah, I know the guidelines say, you must use prophylaxis, and I think it's very patient dependent. So, if you're having a patient who's not actually flaring very often, I think it's quite reasonable to gradually dose escalate them. So maybe if they were on 300, go 150, and then, for a couple of weeks, and then 300 after that. So you're not suddenly dropping the urate. Make sure they've got some therapy so they can treat a flare rapidly. And in reality, I quite often wouldn't prophylax those people. If they're flaring all the time, it's different. But I think, NSAIDs and colchicine are not without their own toxicities. So I think we do need to use our clinical sense in all of this as well.
Thank you.
In acute gout, is the uric acid can often be normal?
Yeah, that's right. Yeah. So if you have a high suspicion for gout, and the urate, and you test the urate and it's normal, usually it's not 0.15. Usually it's 0.38 or something like that. Test it again 2 weeks later, and usually in that situation it'll be much higher. So basically, as part of the acute phase, urate drops. It's not a gout-specific thing. It's actually pretty much any acute phase reaction will drop the urate.
Would you say it should be at least more than 0.3, or it could be 0.25?
So certainly more than. I would be really thinking about my diagnosis quite carefully if it was below 0.36.
Okay.
Yeah.
Okay.
It's a pretty good rule out, isn't it?
Yeah.
Stable and that. Well, I'd just like to thank Nicola. She's had a big day today. She's done 2 clinics and come here. We actually ask a lot of our speakers. We try and get them to give a talk for those of you who missed out in the clinic. But I think this has been a fantastic talk. And we have some liquids here which are
non-alcoholic.
Beautiful urate lowering with any luck.
Thanks, Bruce.
Thank you very much. So, just join in.